Good morning, dear
Okay,
Professor.
perfect. Good morning.
Let's begin our today event, and the floor is given to Professor Maria Pia Foschini from Bologna University. Her lecture is dedicated to carcinoma in situ of the breast. Professor Maria Pia Foschini, you can start your lecture.
Oh, thank you very much. First of all, I want to thank you for your kind invitation. I hope that you can that you will like my presentation. I want to start from in situ ductal carcinoma because it is the beginning of the breast cancer. But before starting, I would like to make some consideration on normal breast. I am sorry, I don't know exactly which is your study plan. And so I did more or less the same lecture that I delivered to my students. And before starting, I want to discuss with you the normal breast, because of course you know that breast is a superficial organ that we use to, for practical purposes, we separate into quadrants. And you know that I think that this is done all over the world. We say the upper outer quadrant, upper inner, and so on. Quadrants can be done in this way. We have the upper and the lower quadrant, external and internal quadrants. And this is very useful for practical purposes. I know that maybe you do the same, I think, in your country. But then, based on anatomy, microanatomy, the breast should be divided into lobes. Maybe, are you confident with the lobe concept? Can you, because if you know, I will be very fast. If you are not confident, I want to spend some minutes illustrating the lobe, because we will discuss the growth of cancer now in situ, and the next week invasive carcinoma based on the concept of the lobes. So what is the lobe? The lobe is there's a microanatomical structure that starts from the nipple. You can see the opening of the galactophorus ducts. This is an opening. And then you see the galactophorus ducts. The galactophorus ducts divide into segmental, subsegmental ducts, and then they end in these TDLUs that I will go to this in a minute. This wall unit is the mammary lobe. What does it mean? It means that, as you see in this drawing, in this picture, each lobe is independent. You see that we can start like a journey. If imagine to be a very, very little entity entering into this opening, in the galactophorus opening, and that you go inside, you can walk through this lobe, but you don't have connection with the lobe that is near. So we have in the breast, we have several independent lobes. And in the lobe, you have this very tiny structure that is the terminal ductal lobular unit, that is the functioning unit. It is the part that produces the secretion. Do I have, of course, we have, this concept is based on anatomical studies. And one of the most beautiful to me, it is, and I encourage you to read this paper done by colleagues in Glasgow, is a three-dimensional reconstruction of the breast parenchyma. And you see, they based their study on autoptic breast of women dead for medical legal purposes. They did not have any breast pathology. You see that this kind of cap, this is the nipple. They reconstructed the breast with the computer. You see that this is the nipple, and these are the galactophorus ducts that you see. Then they injected the galactophorus ducts with colored inks, and then they went reconstructing which are the lobes. And you can see that in the breast of an adult woman, you have different lobes, and you see that the color are not they don't mix up. They are more or less, they can be superimposed one to the other, but then we can have, you can see that basically the lobes are independent each others. Then from this picture, you can see that we have very wide lobes like this yellow and very teeny lobes like this green. You have intermediate, this black, and so on. So this is the basically normal breast. Then this is the picture that I did using a stereo microscope. There is a very simple technique that you can do. It's a very simple and cheap technique in which you can make the breast tissue transparent. And then you look with the stereo microscope, and then you see that the lobes are like this, they independent one to the other. Here we see the breast like, always imagine to be very tiny structure, and you see it in the pectoralis fascia. And you see, so seated in the pectoralis fascia, you see the breast parenchyma, and then you see the terminal part of the lobes, and you see that here we have the ducts, and these are the TDLUs, but then each lobe has the its own TDLUs, independent from the other lobes. On histology, the histology of the TDLUs is this one. We have the duct, small ducts, and then the lobular units. You see they are lined by two layers of epithelium, the inner layer, the epithelium, and then we have myoepithelial layer. You see these clear cells. Here again, you have epithelial and myoepithelial cells. It is very important that the luminal cells, mean the epithelial cells, they express estrogen receptor, progesterone receptor, and androgen receptor. Androgen receptor is very important. Maybe you all are confident with estrogen and progesterone, but we will discuss, especially in the next lesson, that also androgen receptor can be very important. Then we have myoepithelial cells that do not express these receptors. We have great variations, of course, according to the age and the menstrual cycle. We have variations, we have different kinds of cells, for example, these apocrine cells that are rich in androgen receptors. And we have lactating cells that they do not express receptors. But going back to the lobe, Professor Tibor Toth, who is a colleague who is working now in Falun in Sweden, proposed this theory of the sick lobe. What does it mean? It means that the cancer spreads through a sick lobe. And this is very important. These are some drawings taken from Professor Toth pictures paper. And you see that we have cancer starts and then develops through this sick lobe. We can have, and then we will see later, we have multiple lobes involved, but with different cancers. So this concept of the sick lobe is very important, and then we will discuss later in this lesson. Is it clear to you? I mean, do you have question on this part? So if you don't have question, I will go on, and then at the end you can make all the questions that you want. Let's start with ductal carcinoma in situ. What does it mean in situ? In situ is Latin word that means in the same site there. So carcinoma in situ means the carcinoma, the neoplastic cells, are confined in the same site in which they arose. In the breast, we can translate in neoplastic cells within the glandular structures. In this picture, you can see this schematic drawing. This here we represented the normal duct. You see these elongated cells are the myoepithelial cells. And here, these cylindrical cells are the normal luminal epithelial cells. Then they transform, and you see they become atypical, but they grow within the duct. And you see at the periphery, we still have the myoepithelial cells. The in situ duct carcinoma is very important because it is a very early step of cancer. It is important because detecting in situ carcinoma, we have a real possibility to really cure the patient. So which is the incidence of in situ carcinoma? If you don't make mammographic screening, it is the incidence of pure in situ carcinoma is very low, less than 5% of all breast cancers. But if you perform regular screening programs, then in situ carcinoma increases in percentage, pure in situ mean, and it becomes 20 to 30% of the breast cancers. Here you have the correct definition given by the WHO book in the last World Health Organization book was published in 2019. I mean, at the end of 2019, maybe that means a little more than 1 year ago. It was really November, December 2019. So what is written in this book? That DCIS, ductal carcinoma in situ, is a non-invasive proliferation of cohesive neoplastic epithelial cells confined to the mammary ductal lobular system. That means they are within the glandular structure. They do not pass the myoepithelial cell layer, and they do not invade the stroma. Then when we talk about ductal in situ carcinoma, we have a very wide range of lesions that we can summarize in the picture that you can see here. We have very well differentiated cases with cells that clearly resemble the normal cells, and it is grade 1. Then we have intermediate and poorly differentiated cases that we have grade 2 and grade 3. Here, I don't know if your practice with histology, but I think that even if you with normal histology, I think very well that is for practical purposes. And to summarize, we line here to separate grade 1 from grade 2 and grade 3. So, and today I will summarize in this way because we can separate two big families of DCIS, and they have great consequences as treatment and prognosis between the low-grade DCIS, that is basically the grade 1, and the high-grade DCIS, that is basically grade 2 and 3. Let's start from grade 1. DCIS low-grade grows very slowly. In screening programs, we see also the precursors. And I will not talk about the precursors because it is how to treat them is a very great discussion in the world. But I just want to tell you that this grows very slowly. And we can see also the precursors that do not have great impact on the health of the patient. When we have low-grade DCS, the full-blown picture of low-grade DCS, we have mainly elderly ladies in most of the cases, not always, but most of them are older than 70 years. And we see low-grade DCS mainly in mammographic screening programs. What we see on histology, you see low-grade, you can imagine, very well differentiated cells. They very similar to the normal cells. You see it here an example. We have small cells, not basically atypical. They can organize into small papillae. We have micropapillary. We have cribriform if we have these small glandular structures. But basically, all these kind of are composed of well-differentiated cells. Well-differentiated cells, what do? They are similar to the normal ones, so they produce a secretion that is like milk. And if you have secretion that is like milk, you know very well that is very rich in calcium salts. So in this milk is rich in calcium salts, and this calcium salt deposit on this secretion, and they make a structure like very teeny like that are called psammomatous or laminal calcification. Psammomatous derives from ancient Greek. We are very, of course, we are very linked, bounded by our language is very close and derives from ancient Greek and Latin. So most of our words have a base on ancient Greek and Latin. Psammoma in ancient Greek means the sand, the sand granules. So you imagine the sand granules are very small, and these resemble the sand granules. Of course, this very teeny calcification can be detected on mammography. And so in the mammograms, you can see this very, there's very, very teeny deposits, these very teeny halos, and on histology, they correspond to those small calcifications. And this is the sign that the radiologists see on mammograms and indicating in situ the carcinoma of low grade. When we make on molecular biology, of course, they are similar to normal, so they have a high expression of estrogen receptor. Here you can see that is immunohistochemistry. The estrogen receptor, the cells positive, they are stained in brown. You see that most in this is a cribriform in situ carcinoma. You can see that most of the cells are stained in brown by estrogen receptor. And here around, you see that some unstained cells that are the myoepithelial cells. Then we saw, I told you that low-grade DCIS is a slowly growing tumor. And indeed, when we make the proliferative index by Ki67 is again very low. You see that again that neoplastic, the proliferating cells are stained in brown with the anti-Ki67 antibody. And you see that you have just a low number of neoplastic cells staining with Ki67 antibody. So we are very happy. It's a very good, slowly growing tumor. The prognosis is very good because when we detect in situ carcinoma, what we should avoid the progression to invasive carcinoma. So if we have a patient with low-grade in situ carcinoma, which is the risk to develop invasive carcinoma, it is quite low. Maybe about 30% of untreated cases, they can develop invasive carcinoma. In addition, the carcinoma that is related to low-grade DCIS is a low aggressive carcinoma. It is usually a grade 1 or 2 invasive carcinoma. It is usually estrogen positive. So you know better than me that cases that are positive for estrogen can respond very well to anti-hormonal treatment. So we are dealing with a patient with low risk to die for this cancer. So we are very happy. Should we be happy with low-grade in situ carcinoma? Yes and no. Low-grade in situ carcinoma sometimes can be a problem. Why a problem? Because it is frequently means about 75% of the cases, multifocal. That means we have multiple areas of low-grade DCIS in the same breast, or in about 20-25% of the cases, we have a bilateral involvement, meaning that both breasts can present cancer, and cancer can be present at the same time. We have patients that develop two cancers in the right and the left breast, or the second breast can be affected in a second time. This is a large section. You see this is a subcutaneous mastectomy, and in all these circles, you see that are foci of in situ duct carcinoma of low grade. But going back to theory, you see, how can we have a lobar growth so large, involving one breast, almost an entire breast, or both breasts? In this case, we have multiple different lobes affected. We did a study, and if you want, I can share with you the PDF file of the paper, and we made a clonal analysis between the different foci of the CIS. We made the clonal analysis studying the mitochondrial DNA of the cells. We make microdissection of this area. In these cases, we compared microdissection done here and here. And you see, this is a phylogenetic tree in which we compared the DNA, the mitochondrial DNA of all these areas, and also involved by. And you see that in this clonal tree, in this phylogenetic tree, you see that tumors that are related are in the same branches. Tumors that are clonally unrelated, they are in different branches. So you see that we have DCIS in this branch. Reference is the control, internal control. We have in this branch one DCIS focus, then we have another DCIS focus in another branch, and then we have a contralateral breast cancer in situ and invasive, completely separated. So this means that this patient had at least 3 different cancers. That means 3 different lobes involved by cancer. So low-grade DCIS is really a low-grade tumor that in theory could be cured by surgery, or at least you can just make a wait and see. But you must be aware that it can be really multifocal. The patient has really multiple different cancer. So the treatment, the best treatment is very discussed, at least in Europe and in United States. There is no consensus on which is the best treatment for these patients. Because if you make just a quadrantectomy, a surgical resection of the quadrants, you know that the patient can have different foci, different clones, different tumors in the other quadrants and also in the other breast. On the other side, you cannot make a mastectomy because the risk to develop invasive cancer is very low. So you make 70% of these patients do not develop invasive carcinoma. So you would make an over treatment if you make mastectomy or bilateral mastectomies. So now we have trials going on of simple wait and see, especially in Dutch people are very conservative on this way. In Italy, we make something in between. I mean, we make surgery of the mammographically of the microcalcifications. So we take away the most part of the tumor of what we can see on mammography. And then we make close follow-up with mammography, radiology. We try to reduce as much as possible the risk of this patient without making over-treatment. I don't know which is correct. I just propose you what is going on in this moment. So is it clear now on low-grade DCIS? Okay, so I will go on, and then if you have question, we will discuss at the end. Let's move to high-grade DCIS. High-grade DCIS can be is usually present in younger women. We have a peak incidence in women aged 50 to 70 years. And of course, we can see very well in screening mammograms because it is characterized by this granular calcification. They're very well evident and the radiologist can pick up very easily. And this calcification, you see, this is correlation between the mammogram and the histology. The calcification they deposit on neoplastic, on the necrosis. It is very different from the low grade because it is composed of cells with very marked atypia. And most of the cases we have necrosis in the internal part of the tumor, of the duct. And when necrosis is present, we call it comedocarcinoma. This is an example. You see, we have the neoplastic cell, they grow, they grow in a solid way, and make any glandular structure. They just grow. They're very aggressive. They grow massively, and they grow very fast. They don't have blood support, so they go to necrosis. It is a comedo type necrosis, and in this necrosis, on the residual cells, on the dead cells, we have deposition of calcifications, and this calcification you see very large, very irregular, and they can see very, very easily on mammograms. Here another example, you see that you have this solid production of solid growth of neoplastic cells with comedo type of necrosis. Sometimes don't have to detect with radiology, and especially can be difficult for radiologists and for surgeons to understand before surgery how large is this high-grade DCIS area. What happens on molecular biology? We have very, very aggressive lesion tumors, cells. Sometimes we can still have positivity for estrogen and progesterone receptors, but in numerous cases they are negative for estrogen and progesterone. But we have a positivity, the high, very high expression of human epidermal receptor. We'll go in more details on this HER2 in the next lectures on next Friday on invasive carcinoma. So today I just make this point. You see that this is in situ, high-grade in situ carcinoma, and you see that this is HER2. It is definitely high, very, very highly expressed. And then you see this neoplastic proliferation with the Ki67, and you see that numerous cells, numerous nuclei are brown. That means they are positive for Ki67. So we have a proliferative index very, very high. So it is a rapidly growing tumor. We almost never see the precursor also on screening mammograms. So we have an aggressive tumor, but which is the prognosis? The prognosis is good because we have the possibility to treat them by surgery. If we detect high-grade DCIS, pure high-grade DCIS, we can have the possibility to make radical surgery to take away the whole tumor, and the patient is basically cured. When we make radical surgery in high-grade DCIS, the risk to progression to invasive cancer is very low. But if we don't take away the high-grade DCIS, the risk to develop invasive carcinoma is quite high, is up to 50% of the cases. And then which kind of tumor is associated with high-grade DCIS? We have a high-grade invasive carcinoma, one of those carcinoma that can kill the patient. And it is usually aggressive invasive carcinoma. with little or no expression of estrogen and receptor. And you can have this proof that invasive carcinoma is very aggressive from this paper. This is a paper based by the colleagues from Sweden, Professor Toth and Professor Tar. They did, going back to their series. These is a very large series. You see more than 1,000 patients detected on screening mammograms in the 70s. So after 25 years, you see that mammographically the breast cancer detected with screening mammograms, they had very good prognosis. Some of them, they were all alive and well. Other, you have of course a risk of death in more aggressive cases, but you have more than 90% of the patients alive and well after 25 years. That means that you have the possibility to really cure this patient. But look what happened to the cases related to high-grade DCIS. You have after 25 years, only 57% of patients alive and well. 57 compared to more than 90%. So you can have the idea that these high-grade tumors associated with high-grade DCIS, they are really very aggressive, even when they are very small. So we have a chance, we have the possibility to cure this patient, but treating high-grade DCIS. And surgery is very important, is basically important. Radical surgery in these cases can save the patient's life. But of course, we have, it is not always very simple, because high-grade DCIS sometimes can be very large. When can it be very large? When it involves a very large lobe. High-grade DCIS is a really lobar disease. But you can see, like, we have this wall sections, macro sections, and you see this is the area involved by high-grade DCIS. It is compact because we have the, you see the main duct, and here we have all the subsegmental ducts. They're very compact, very close. You can have safe margins, but you must make a wide resections. This is another example. You see, this was a mastectomy because this is a very large tumor area. You see, here you can see and here you can solve by the tumor while it is not the remaining. So in this case, it was not possible. Our surgeons and the radiologists decided that it was not possible to take away just half breast. It was not suitable to reconstruction. In other cases, you can have like this. You see that the compact area of in situ duct carcinoma that has this typical lobar growth. You see, this is more or less, we can make a schematic representation like this. This is more or less a triangular growth with the point going toward the nipple. So the tumor develops in the duct and in all the segmental and subsegmental and TDLUs of one lobe, and it grows to the nipple. This is very important, the growth toward the nipple. And it is always the same tumor. If we go back again with our studies, to our study done with the clonal analysis, we can see, for example, in this case in which we have this in situ carcinoma going from here to here, we make macro dissection in these two small areas. And you see that the two DCIS are completely in the same branch of the tumor, of the tree. This patient had another cancer in the other breast and it was not related, but in this breast, the DCIS, all the foci of DCIS, they were clonally related. So we have a tumor that is growing into a lobe. But what is going the lobe? The lobe is going toward the nipple. So we can see, you can see in the galactophorus duct, the neoplastic cell that they climb the duct. You see here, the neoplastic cells are stained with most often they are HER2 positive. So you can see the neoplastic cells, they have with strong membranous positivity for HER2, but you see that this highlights a kind of pseudopodia of the neoplastic cells. And you know that the neoplastic cell produce pseudopodia then when they move. And you can see in these cells climbing the ducts, these pseudopodia, and you see the duct, the galactophorus duct, filled with neoplastic cells, and they going to the epidermis. And what you have, you develop the Paget carcinoma of the nipple. You see, these are other pictures. Here you see the epidermis. You can see very well the normal epidermal cells. And then you see these, they are very different neoplastic cells in the epidermis. You see the epidermis is filled with very atypical neoplastic cells. And then in this other image, you can see this is a low-weight cytokeratin that is typical of the neoplastic cells. And you see the epidermis, this is keratin. The epidermis is stained in blue, but there's no low-weight keratins. And all the neoplastic cells, they filled the epidermis, which is the clinical picture. The clinical picture is that you see a woman who presents with a nipple erosion, and then this nipple erosion doesn't heal at all. You must pay attention because at the beginning can be very subtle. You can have a small cell, rare cell, like in this case, you see the epidermis, you have just very little amount of cells, or you have a massive involvement of the epidermis, like in this case. Of course, the clinical picture will be very different. In this case, you have a very subtle kind of dermatitis-like picture. In this case, you have a very well evident nipple erosion. So you must be very conscious, very careful in evaluating your patients, because even very initial cases with very mild clinical presentation, they can have, and why it is important to detect Paget carcinoma, because in more than 90% of the cells you have in the underlying duct high-grade invasive DCIS or invasive carcinoma of high grade. And remember all that you can have high-grade invasive carcinoma is frequently associated with high-grade duct in situ carcinoma is frequently associated with high-grade invasive duct carcinoma. So, and when you see this nipple erosion, it can be the first presentation, can be the spy of something very important, very dangerous that is happening in the nipple. So which is the optimal treatment of high-grade DCIS? It is quadrantectomy, because you know that more than 75% of these cases, they can be, they have a lobar growth, and they can be cured just with surgical resection of the neoplastic area. But you must be very careful in making surgical resection with clear margins. And the clear margins is considered a minimum distance from tumor to the margins of 2 millimeters. And if the margin is closer than 2 millimeters, you can add the radiotherapy. Radiotherapy is very important to reduce the risk of recurrence. But you must make radical surgery. As I anticipated, radical surgery can be quite sometimes difficult because you have the tumor spreading through a very large lobe, because not all the tumor produces microcalcifications. So the mammogram can be misleading. Sometimes you can have the tumor larger than what is detected on the mammograms, because you have areas of the tumor that do not have microcalcifications. But nevertheless, this is a very important challenge, because taking away radically the high-grade DCIS, and then you can do, because it is a lobar disease, you can really save the patient. I did not bring too many statistical data because I didn't want. You can easily find papers, and then if you want, I can send Professor Kaharov the PDF files if you want, and you will find in larger series that high-grade DCIS, when it is surgically treated, radically surgically treated, had a wonderful prognosis. But if you live in situ, you have a very high risk to develop invasive carcinoma. Low-grade DCIS, again, is this contrary. Of course, we can have, we can cure, we can manage, but you must pay attention that you can have multiple foci. The upper outer quadrant is the most frequent site of cancer starting. You can take away the greatest part of the tumor, but you reduce the risk to develop invasive carcinoma. But then you must be aware that you can have other microscopic foci of DCIS that are clonally independent. They are different tumors affecting different ducts, different lobes, but they can be present. So you must make a very, very close follow-up study. And this was the last. I thank you for your attention. And you see that sometime in situ that carcinoma can be challenging. You see like this phase. And please, if you have question, I have time I will try to answer your questions.
Thank you very much for your interesting presentation. And it was one question from the floor, and it was how androgen can affect the DCIS growth. They asked in the chat.
You mean androgen receptor?
Yes, androgens.
Yes, androgen receptor is very important. I will talk better during the next, in the next Friday, we will talk about breast cancer, invasive breast carcinoma with all the biomarker, and we'll go in more details with androgen receptor, and also I will talk a great deal of androgen receptor in with male breast cancer. And normally present in breast, both in male and in female breast. They are present both in epithelial and in the stromal cells. And especially, I studied androgen receptor, especially in male breast cancer. We have imbalance of androgen receptor is on X chromosome, and we can have both in males and in females imbalance of the X chromosome, and that could be a first step of neoplastic transformation. But if I am preparing this for the next lecture of next Friday. So if you have, I'm preparing pictures and images, so I will go in greater detail.
We will waiting for your next presentation.
Yes, so I hope that you will enjoy it.
Allow me on behalf of the administration of Tashkent State Dental Institute to thank you for taking the time to participate with highly informative and interesting report, and in the work of School of Oncology for medical students, as well as all participants in today's event. The conduct of the oncology school is extremely important for the formation of oncology alertness. So see you to our next event. Thank you for your attention.
Okay, thank you for inviting me, and I really hope that it could be useful. And then
thank you. See you next time. Bye.